Good morning again, and welcome back to our second session of day 2 of MPHA's annual conference. We're excited to be joined by Kimberley Fox, Senior Research Associate at the University of Southern Maine, and Yvonne Jonk, Deputy Director of the Maine Rural Health Research Center. This morning, they will be presenting on trends in youth use of telehealth for health and behavioral health services in Maine prior to and during the COVID-19 pandemic. As always, a couple announcements before we start the session. If you need access to closed captioning, that's available below the video in the session. We encourage you and ask you to please take the evaluation at the end of the presentation, available through the feedback button. And if you have any questions for our presenters, please enter those in the Q&A and we will take them at the end of the presentation. And don't forget the poster reception at 4 o'clock today. So thank you, Kim and Yvonne, for being here, and I will turn it over to you for your presentation.
Great, thank you for that invite, and also to MPHA for having this forum and allowing us to present results of our work that we've been doing. So we're here today to talk about a study that we've been doing to look at children's and adolescents' use of telehealth for behavioral health and health services in Maine prior to and during the pandemic. These analyses were conducted as part of a larger study. I'm going to move on to the next slide, that was funded by the University of Maine System Rural Health and Wellbeing Grand Challenge Grant. It was designed to investigate children's telehealth use and barriers to inform research and training of health, behavioral health, and allied professionals in telehealth. And I also want to acknowledge our data partner, the Maine Health Data Organization, which provided data for this study under a memorandum of understanding with the University of Southern Maine, which also is there to help support research and workforce training in health data analytics. Although not identified on our slides, I also want to thank and acknowledge our research team members at USM that also participated and helped with this presentation: Deb Thayer, Erica Swan, and John Massey for their contributions to this study over time. So we're gonna, this next slide basically just talks about what we plan to cover for the in this session, which is to define our research objectives and methods and present results. So I'm gonna keep going to the next slide. I'm gonna start with talking about our research objectives. The goal of our analysis was really to assess how telehealth policy changes affected children and adolescents' telehealth use pre and during the pandemic, and how it helped address gaps in care, particularly for children with chronic health, developmental or behavioral health needs. We wanted to examine children's use of telehealth across payers and geographic regions within the state, and identify specific variables, socioeconomic, health risk, or provider factors that may be associated with the use of telehealth services prior to and during the COVID pandemic. So in terms of a little context, we had undertaken a previous study of adults in Maine. We know that rural Maine children face greater barriers to accessing needed services given limited supply of providers, and especially for those that are residing in the most remote areas that are medically underserved areas in the state. Telehealth can provide an opportunity to improve access to needed health, developmental, and behavioral health services to children in those, particularly again in underserved rural remote areas. And even pre-pandemic, Maine was aware of this and had passed a lot of telehealth supportive policies to encourage greater telehealth use, both in the Maine Care program, which already had pre-pandemic payment parity and audio coverage and a variety of really progressive telehealth policies, as well as in our commercial insurance laws, which passed parity back in 2009. We were one of the first states to do that. So we had already been wondering or wanted to look at the effect of those policy changes. And then, of course, COVID hit during 2020, which then resulted in even more public health emergency related telehealth coverage expansions, both within Maine Care and for the commercial insurers. The insurance regulated that they also expand to audio only and allowing for parity in payment as well. So all of those set a sort of natural experiment for us to be looking at the impact in the pre and post COVID periods. So this next slide probably is not particularly news to those of us that live in Maine, but I just want to always remind people of how rural Maine is relative to our other northern New England states. And more than 60% of Mainers live in rural areas of the state compared to 20% nationally. So this is an important, telehealth can be potentially a really important way to reach people in these remote areas. In terms of our methods, I will just say we used the data source that we used was the Maine All-Payer Claims Database, which is a comprehensive set of claims from commercial insurers, Medicare, Maine Care, and many other pharmacy benefit managers, et cetera. For this study, we had data from 2014 to 2020, and we really looked at Maine Care and commercial claims because they largely covered children between the ages of 0 and 18. And we identified telehealth claims using modifiers like in GT, GQ, and also 95, which was added and during COVID, and telehealth specific CPT and HCPCS codes. Those are procedure codes. Sorry, I'm using a little bit of lingo here in these slides. We also used Johns Hopkins adjusted clinical groups to adjust for health risk. And we also looked at geographic variation using the rural urban commuting area codes. Next slide, please. So I'm just going to jump to our results. So as you can see on the slide on the left, the percent of children that had been using telehealth pre-pandemic, while it had been increasing between 2014 and 2019, it still remained pretty low, highest in Maine Care, but only at around 3% in 2019, which was around 4,000, a little above 4,000 kids in the state that were using telehealth. Whereas obviously in 2020, you see that huge increase in telehealth use, particularly again for Maine Care children. It went up to 19.6% of Maine Care kids. But even in commercial insurance, where it had been almost 0 in 2019, it went up to 19.5% of kids. And the slide on the right shows a quarterly drill down to just sort of explain that the largest spike in telehealth was in that first quarter of 2020 when the public health emergency just started and a lot of offices were closed. And it declined somewhat, as you can see in the quarter 3 and 4, but it's still significantly higher than it was in the pre-pandemic period. So people were continuing to use telehealth into 2021. Next slide. This slide shows that what has also been seen nationally is total children's healthcare use during the pandemic declined, particularly in that second quarter when in-person services were restricted, but really maintaining even in the third and fourth quarters. Telehealth, which is shown in the yellow here, basically helped, but certainly did not completely overcome this downward trend. But you can see that it really helped a lot in terms of trying to get people access to services that they might not otherwise have been receiving. In terms of the services, the next slide, please. We're going to, the pre-pandemic children were primarily using telehealth for behavioral health and speech language services. You can't see it that much on this line because there wasn't a lot of telehealth use, but those were the primary services being used. Whereas in 2020, the largest increase was really in behavioral health and also in other services, which is represented by that gray line in this slide. But across the board, there was obviously increasing telehealth use in office visits and speech language pathology as well. On the next slide, you'll see that there was also a huge increase in the number of providers that were using telehealth. Most dramatically in the behavioral health providers, as well as those doing office visits. The unique providers, billing providers, and rendering providers are those that are individual providers within a larger billing system. So they really show huge increases from the prior year period, from 152 in 2019 to 2,811 providers in 2020. and which is a huge increase. This also reflects the telehealth service use that we saw on the prior slide, and with the greatest increase in those office visits and behavioral health. Office providers, just to give you a little sense of who those are inclusive of, they're most of the major health systems and physician groups, FQHCs and specialty providers were amongst those providers that were now providing telehealth. And also there was an increase in schools as providers of telehealth, both in behavioral health and speech language services, which was the target of our study, was to see how much telehealth was being used in rural schools. Within the providers, there was also, I should note here, considerable variation in terms of how much they use telehealth. So there were some that were using it for a lot of visits, and probably around a third of them that only used it for 10 or less visits. Next slide, please. So this shows the difference in the telehealth use by rural and urban areas in terms of, and also the distribution of the types of services that they were using. So pre-pandemic, those bars are pretty small, but you can see that telehealth was being used in both rural and urban areas. In the pandemic, it occurred in both places, but urban had a much larger increase in terms of its use of telehealth, absolute anyway. And in terms of the distribution of services, prior to the pandemic, the rural children, as I said, were sort of more likely to be using speech language pathology, as represented by that sort of yellow bar over in 2018, whereas in 2020, the distribution of services and the types of services were pretty consistent across rural and urban areas in terms of service use. So the next slide shows us, this is a little bit of a further drill down of the conditions that were being treated via telehealth. And it reveals that, really 2/3 of children's telehealth claims were to treat behavioral health and developmental disorders, both before and during the pandemic. The use of telehealth that's noted here to treat neurodevelopmental disorders actually went up in 2020. They accounted for around 1/3 of claims, which was up from 1/4 in 2018, which we thought may be associated with services needed by school children with special needs as part of their individual education plans and behavioral health. But we need to investigate that further in terms of where we're seeing the increase in terms of provider site. And the next slide, I think I'm going to. And this just shows you that telehealth was being used for a broader array, which was referenced in the other visits. There was a wider variety of primary diagnosis on claims and telehealth claims for kids in 2020 than in 2018, and many more types of diagnoses. And those new diagnoses in 2020 included a lot of more medical care, primary care, asthma, dermatology, diabetes, reproductive health. So there was far more variation in the use of telehealth in terms of the primary diagnosis of the kids. And now I am going to hand it over to Yvonne to talk about what we found in terms of telehealth users' characteristics and factors predicting use.
Thanks, Kim. So here we'll look at the demographic and health status characteristics of telehealth users compared to non-telehealth users, and then identify factors predictive of the use of telehealth. So in the top left-hand portion of this slide, in the years 2018 through 2019, prior to the pandemic, telehealth users were more likely to be covered by Medicaid. And during the pandemic, a larger share of telehealth users were commercially insured, so up to close to 30%. Moving to the left, we see that in the pre-pandemic period, 47% or almost half of telehealth users were age 7 through 12. And then in 2020, this shifted and a larger share of telehealth users were in the older age groups, 13 to 18 years of age. Across all the years, in the bottom portion of the slide, you see that almost two-thirds of telehealth users lived in urban areas of the state. So prior to the pandemic, telehealth users were more likely to live in more remote rural areas than children who did not use telehealth. And that shifted during the pandemic when the growth in the use of telehealth was largely concentrated in urban and large rural areas. Next slide. Sorry. So as we saw in the previous slide, a larger share of telehealth users were commercially insured during the pandemic. And this compares to children who weren't using telehealth, whose coverage was split 50-50 between Medicaid and the commercially insured. Next slide. So while telehealth users tended to be older in 2020 than in 2018, non-telehealth users were split fairly evenly across the different age groups. Next slide. So this slide illustrates the geographic distribution of telehealth and non-telehealth users throughout the state prior to and during the pandemic. So while approximately 2/3 of our children's population lives in urban areas, during the pandemic, the growth in the use of telehealth was largely concentrated in urban and large rural areas. So thus we see a shift in the use of telehealth from small and isolated small rural areas to urban and large rural areas. So more on this when we take a look at the factors predictive of the use of telehealth prior to and during the pandemic. Next slide. So here we look at the health risk profiles of telehealth users versus non-users. So prior to and even more so during the pandemic, telehealth users tended to be sicker than non-telehealth users and fall into the moderate to very high morbidity categories as classified by Hopkins resource utilization bands. Next slide. So here we're looking at the factors predictive of the use of telehealth. And so logistic regression confirmed that the likelihood of using telehealth was higher in 2020 during the pandemic compared to the pre-period 2018 and 19. For children in the higher health risk categories, which are the resource utilization bands 3 through 5, the odds of using telehealth were 75 times higher for those in the highest risk category than those in the lowest risk category, which were essentially children who were healthy. The likelihood of using telehealth was also higher for older children aged 7 through 12 and 13 through 18, and for children on Medicaid. Now, in terms of what was going on in urban and rural areas of the state prior to and during the pandemic, as we mentioned in previous slides, we saw a shift in the use of telehealth from small and isolated rural areas to urban and large rural areas. So in order to capture the shift in the use of telehealth across these geographic areas, we included an interaction term for rural and time period so that we could differentiate between the pre-pandemic period, which was 2018 through 2019 in these analyses, and then the pandemic in 2020. So in the pre-period, we see that the odds of using telehealth were 1.4 times higher in small and isolated rural areas than in urban and large rural areas. So we see that the coefficient, the odds ratio for small isolated is 1.4. Then within urban and large rural areas, we see that the odds of using telehealth were 23 times higher during the pandemic versus the pre-period. So that's the odds ratio on the term pandemic in this slide. And then finally, the interaction term, which is 0.6, tells us that the expected increase in the use of telehealth during the pandemic was on average 40%, which is 1 minus the 0.6. It was 40% lower in small and isolated rural areas versus urban and large rural areas. So we believe that the shift from more remote rural locations to more urban locations is a reflection of the barriers to implementing telehealth in rural, such as the lack of broadband or internet access. In other words, urban and large rural areas were probably better positioned to make the transition from in-person to telehealth during the pandemic and take advantage of lifting of the restrictions to using telehealth because of greater connectivity. And Kim will cover those key findings in policy implications again in the next slide. Thanks.
You're welcome to join me, Yvonne, on these as well. But the key findings obviously were that the percent of children using telehealth has been increasing over time, but with the greatest increase really occurring during the COVID-19 PHE, which we think is related and directly related to the policy changes that occurred to expand telehealth during that period. Medicaid has always been the primary payer for telehealth across all years, but again, in the pandemic, there was increased commercial use, probably because of the changes in regulatory oversight of commercial insurers to require payment parity and coverage of telehealth relative to in-person. Although the pandemic resulted in significant declines in the use of health services overall, we did see that telehealth use helped offset, but not overcome that downward trend in terms of maintaining access to kids, and particularly based on Yvonne's results, particularly for kids that were a high risk, which is good news that the telehealth was actually providing services to kids with the greatest need. Telehealth was primarily used for developmental and behavioral health services, both pre and during the pandemic, but definitely saw huge increases in use for behavioral health in particular, to meet the expanding needs and behavioral health issues that were probably occurring in the children population during this time, and also other medical care needs. So the logistic regression, Yvonne already covered what it confirmed, but it basically told us that the likelihood of using telehealth was higher for children in those higher risk categories. And in the PHE, I don't need to cover all those because I think she already has. In terms of policy implications, the telehealth policy leniencies during the PHE, we believe helped children maintain access to services, but did not offset that overall decline. The relative increase in the use of telehealth among children living in the large and urban areas really, compared to the more remote rural locations, is potentially indicative of other barriers, not about necessarily reimbursement, to expanding the use of telehealth in rural areas, such as limited broadband. I think we want to do further research to sort of assess where, with looking at broadband in terms of how it may be affecting rural use. We also believe additional analyses are needed, which are underway to assess the impact of specific telehealth policy changes, specifically like audio only, whether that made a difference in rural areas in terms of greater use, to just inform which of the telehealth coverage expansions should be maintained post public health emergency and pandemic. We have done some preliminary analysis looking at audio only, and at least preliminarily, it doesn't appear, it accounted for around 10% of telehealth use during this period, and didn't see a lot of variation across rural areas and versus urban. But I do think that one of the limitations of this study that we just always want to note is that we can only count what people count in claims. So we know that especially when the telehealth leniencies were put in place, there was less of an incentive necessarily to indicate that it was a telehealth specific visit because there was parity. So we are only able to capture what people coded. And we believe that this probably underrepresents the amount of telehealth being provided in the state, because we know more anecdotally that some providers, the variability of how they code makes a difference in terms of what we can capture in terms of telehealth use. But that is it, I think, for our presentation. Yvonne, is there anything else that we want to add? We want to leave some time if there are any questions, but we are really excited to be able to share this information with you and to be able to show that telehealth has made a difference to kids in the state during COVID.
I just want to add that, we're interested in looking at place of service and identifying the extent to which telehealth was used in school-based settings, which was somewhat challenging for us. And we don't believe that that's also consistently coded. And so we weren't able to directly address that. But when we started this adventure off, that is one of our key questions, was to try to assess that. And we were not, we did not present those analyses just because we believe that that's probably undercoded as well as the audio. You have anything to add to that, Kim?
No, I'm wondering if there's any questions at all that we could add.
Yes, we've had several questions come in. I'll start with one clarifying question. Does the non-telehealth group exclusively represent individuals that attended appointments in person, or does it also include those that did not seek care in any setting?
The non-telehealth would only include people that actually sought care because we were using claims. So they had to have gone in, you know what I mean, be billed for a service. So it would be anyone that was not, did not have at least one telehealth claim.
Okay, thank you. Another question that's come in, did your study look at whether there was any change in health outcomes as the use of telehealth increased?
That is a great question. And I think that's our next step. Right now, we are just trying to identify the impact of telehealth. I do think that it will be, especially, we may want to look at subpopulations in particular. We only, as I said, we presented a little on the conditions, and there's such variability in the conditions being treated that we would probably want to drill down into specific groups, you know, where we can measure outcomes that are applicable for those particular conditions. But I do think that, especially for behavioral health, we may want to be looking at continuity of care, how it helped basically keep people connected to their behavioral health providers. So there are measures more of, I guess, continuity of care and length of stay that we might want to be looking at in terms of an outcome. As it's a little, I will just say, many outcomes are not necessarily captured in claims, but there are outcomes like basically, you know, not using the ED, other inappropriate service use, those kind of outcomes we could potentially measure. But we have not done that yet. Yvonne, is there anything else you wanted to add to that?
No, I think you captured the ED visits and, you know, et cetera. It depends on, you know, how the person asking the question is thinking about health outcomes. But what we typically do with claims data is look at their use of emergent services, because that's a low-hanging fruit, right? They're expensive, and we try to you know, do our best to prevent people from having to go in. So we do pay attention to that as a health outcome.
And that may be
thank you.
Next step.
Oh, I was going to say, it sounds like you might have an abstract for next year's conference.
We hope so.
Are you able to elaborate at all on your findings as they relate to urban areas with concentrations of Black, Indigenous, and people of color? One city, the questioner gives the example of South Portland, that was ill-prepared to pivot delivery of services during the lockdown due to assumptions about connectivity and accessibility.
I might need you to repeat a part of that question, but in terms of racial data, unfortunately in the all-payer claims database, that is not necessarily well populated. So we weren't able to look at variation by race but we may in the future, because I know that the Maine Health Data Organization is working right now to improve data collection of race. And the second part of your question was related to I just missed South Portland. I heard South Portland, but can you just?
Yeah, you answered the question. It was just more elaboration to give some context.
Okay.
If I can add to, you know, one possible solution is we do have race in the Medicaid or the Maine Care data. So you know, we have not gone down the road of trying to merge that in to what we're seeing in the all-payer claims database, but I do know that MHJ is working on that, as Kim alluded to, and in terms of trying to improve the data that we have in the APCD. But you know, because the primary venue is Medicaid in terms of the use of telehealth here in the state of Maine, it might be worthwhile to take a look at that within Maine Care data.
Yeah. And we know our partners at Maine Care have actually done some analysis, I think, by race of telehealth. So we could build off of that at working with them.
Yeah.
Great, thank you. And we have about 30 seconds for one more question. Did your study collect any data on missed appointments or attendance of appointments in general with the increasing use of telehealth?
We did not, but again, I love hearing those questions because they might help us in informing our sort of next steps in this analysis. Missed appointments could be an outcome essentially, or to at least track at the differences in when you use telehealth or not. We also may be, although it's a little hard to do with claims, but we have done other travel distance, avoided as a result of telehealth. That could also be something to look at. But missed appointments, as we know, increases a lot because of transportation barriers. And so telehealth may have actually contributed to reducing that.
Great. Well, thank you both. Unfortunately, that's all we have time for. These shorter presentations seem to go by very quickly. And I know there's always lots more to discuss, but we really appreciate you both being here to present this morning. And as we said, hopefully you'll be back next year with more on this study so that we can continue learning about the use of telehealth. But for now, we will take a quick break and come back at 10:20 to learn about strengthening supports findings, rural models of collaboration. Please remember to take the evaluation, and we will see you at 10:20. Thanks, everyone.
Thank you.